Here we are. Good. So let's talk about the revascularization. I think that everyone knows that when we have an ulcer or we have a critical limb ischemia, what is important is to bring the blood to the foot, because this is the key point to save the foot and stimulate the healing of the lesion. Obviously, there are two key points that we have to keep in mind. The first one is the number of vessels. This is an old story, especially Roberto Ferraresi stressed this concept that we know that one vessel could be enough, but if we can have two vessels, obviously this is better, and three is much better than two. But sometimes also we don't know during the procedure if we are able to reopen or restore the perfusion to all the vessels, or there is just one. And the other element is how we bring the blood to the lesion, because we can have a direct revascularization when we create a straight pathway, bringing the blood flow direct to the target lesion, or we have an indirect revascularization that is basically correlated to the presence of some collaterals. There are data that are supporting a big difference or supporting the direct revascularization, because in this way we can achieve a better healing ulcer, and also we have a high-speed flow that can stimulate much better the healing. However, this is sometimes not possible because maybe there is a heavy calcified lesion, a long occlusion, an old occlusion. So we have to think about how to bring the blood down there. And definitely we can work through some collaterals. And this is also very important to find a large pathway, a large network that can stimulate the healing of the lesion. There are some data that are completely, however, in favor of a direct revascularization. This, for example, was a prospective single-center study. They compare the results of the direct revascularization versus the non-direct revascularization. You can see what is important, that also the blood volume was tremendously higher if we have a direct revascularization, as well as also the flow time, so the flow velocity of the blood. And all this stimulate much better the outcome for those patients with a critical limb ischemia. They also analyze here, you can see from these images, the rate of blood volume, and you see a much higher if we have a direct revascularization versus the indirect revascularization, and also the rate of time to peak, so the flow velocity again is much, much higher if we can create a direct channel to the foot. This was also confirmed by this retrospective single-center experience of more than 100 patients, where they perform the revascularization according to angiosome concept. And again, you can see here, after 1 year follow-up, they reported that the healing rate was tremendously higher for the direct revascularization, 70% versus just 34% if they achieve an indirect revascularization. But also the time to healing, you see 7 months versus 10 months. And very important, also the rate of major amputation, higher if we have an indirect revascularization, and also as well as the major amputation-free survival. This is, again, the scheme that is very interesting in my opinion, because you can see the difference between the two techniques in terms of ulcer healing. And this is much, much evident with the time frame, because at 1 year, you see the gap between the two lines is much evident there at the beginning of the procedure. So again, this tests the concept that every time we are working in a critical limb condition or in below the knee, we have to do all our best to create a straightforward channel down to the foot. This concept is also underlined by this paper. There is guidelines from several societies, including the Society of Interventional Radiology, the American Heart Association, published this here. You can see that they stress the concept that the goal for CLI-TI patient is to create a pulsated flow down to the foot following the angiosome. And if you cannot achieve a direct revascularization, you have to work through collaterals. But very important to find a large collaterals that you can create a good flow down to the foot. Again, a couple of months ago, this paper was published regarding the evaluation of the foot perfusion evaluated with endocrine green fluorescence imaging before surgical or endovascular revascularization. Not a big number of patients, 72 fit, but you see what's very interesting because they already stressed the concept that the mean maximum intensity was much higher if they can achieve a direct revascularization. So this tests again this concept that also perfusion in the foot is much better, not only in the area, in the target area, but on all the foot using a direct revascularization. However, there is something that I would like to share with you because 1 year before, this is 2023, this study was published as a prospective cohort, again evaluating the flow at the level of the foot with near-infrared fluorescence imaging using endocrine green, 52 patients, but according to them, there was no differences in terms of perfusion between direct and non-direct revascularization. And this is a little bit strange because it's completely on the opposite side of the river if you compare to all the other data that we showed before. And there is a clear picture. You see the direct versus indirect. Obviously, there is a big difference between pre-treatment and post-treatment, but not big differences in terms of outcome correlated to the two different techniques. So in conclusion, however, we can affirm that it's very important to achieve a direct flow going to the foot because this can reduce or increase the amputation-free survival, reducing the complication rate and the major adverse events. What is important, if we are not able to create a direct flow, we have to look for collaterals that can perform enough a good pathway and so stimulate the healing of the ulcer in any way. Thank you for your attention.